Good day, everyone. Let me start by congratulating MT and Svin for removing the clots and the clogs in ensuring that those who require thrombectomy to recover from acute stroke are able to get these services. For this World Stroke Day webinar, I am privileged to talk about building thrombectomy systems of care in Sub-Saharan Africa. The World Stroke Day for this year, the theme is Be Greater than Stroke. So together we can build systems that will make us to defeat stroke, even in Africa. Needless to say, NCDs cause 7 out of every 10 deaths. And we know that stroke is the second leading cause of deaths. And is one of the fastest growing cause of deaths and a leading cause of disability adjusted life years. And it costs close to $1 trillion every year. That's from the work we did with the Lancet Commission on stroke. So among neurological conditions, of course, stroke is number one in terms of disability adjusted life years across the globe, including, of course, in Africa. So we thought this was a huge problem and that a global response is needed. This was myself with Walter Johnson in his office in the WHO headquarters in Geneva. And we thought there should be a commission, a Lancet commission, to bring the attention of the world to the importance of dealing with stroke. So the work of the Lancet Commission lasted 6-7 years, at least, in creating what the pragmatic solutions are. And we came up with 4 pillars of the quadrangle: surveillance, which helps in monitoring risk factors, health services; prevention, to reduce modifiable risk factor or control them; and acute care, which is to plan healthcare services, train workforce, capacity building according to quality indicators, and of course rehabilitation. We will be focusing, there is of course the healthcare systems and resources. We will be focusing on acute care, specifically, because that's the mission of MT, mission thrombectomy. So we looked at state of stroke services across the globe. And as you can see, in Sub-Saharan Africa, for surveillance, for prevention, for acute care, for rehabilitation, Sub-Saharan Africa performed the least. Acute care services was available in less than a third. And we also looked at guidelines, LMICs versus HICs. And you will see for acute care, in terms of number and in terms of quality, you will see that LMICs, particularly low-income countries, are the least. So 4 pillars of the stroke quadrangle. This was launched last year, October 2023, with projection and dissemination across over 300 news media, including CNN. But what is more important is getting these pillars to be implemented. And that's what we are discussing today. How do we ensure that the pragmatic solutions are implemented across the globe, including, of course, in Africa? So if we don't do this, it's been projected that by 2050, up to 2050, the burden continues to increase, particularly in Africa. As you can see, Sub-Saharan Africa, you can see the burden continues to increase. Ischemic stroke, hemorrhagic stroke. And the number of deaths, particularly in LMICs, will continue to increase. So also the costs. So what are the key recommendations? They are across different pillars: surveillance, rehabilitation, prevention. But our focus, like I mentioned, is on acute care, to ensure effective plans for acute stroke care services through which people have access to training, certification, there is enough equipment, treatment, and affordable medicines. Create regional networks to help stroke patients get treatment quickly, because time is brain, and then ensure that stroke care networks work with all relevant stakeholders to provide high quality care for stroke patients, all the way from prevention through acute care to rehabilitation, the entire care continuum. So we looked at ischemic stroke specifically. This is in the supplementary document. We identified level A or level 1A recommendations across different high quality guidelines. The one I'm going to be focusing on, of course, I mentioned thrombolysis, but more importantly, I'm going to mention thrombectomy. That patients with large vessel occlusion with symptoms of up to 24 hours should be evaluated for mechanical thrombectomy in comprehensive stroke centers, advanced stroke centers, and this is supported by several guidelines, AHA Canadian, World Stroke Organization Action Plan in Europe. Level 1A, but what is needed to accomplish this? Comprehensive stroke centers, neurointerventionalists trained, available 24/7, anesthesiologists, access to angiography units, devices for MT. Because the way we did the Lancet Commission, we did not just come up with recommendations and level of evidence for such recommendations, but resources required for implementation and what the barriers are. The barriers are lack of knowledge, lack of structure in hospitals, lack of resources to pay the professionals and devices, lack of trained neurointerventionalists. And we need to then set up ecosystems, holistic ecosystems involving government policymakers, hands-on in high volume center in terms of training those who are going to do this, and the Lancet commissioners and ambassadors across the different countries. So, according to the guideline, of course, there is minimum stroke services, there is essential stroke center, and then advanced stroke center. And it is in this advanced stroke center, of course, we have to ensure that we have minimum stroke centers in as many places as possible. This will then grow or expand to become essential and eventually advanced. And that is the pathway. So with the advanced stroke center, then it's possible that these centers, of course, offer geographically defined acute stroke units, staffed by multidisciplinary team that includes physicians, nurses, physiotherapists, and so on and so forth. Inpatient rehabilitation is offered. Patients can undergo thrombectomy or other vascular surgeries or neurosurgeries that may be required. So our goal for the Lancet Commission is that by 2030, the number of countries without acute stroke services in 2022 we should have such services, and the number of new acute stroke services should also have increased in each country. So, but we looked at the barriers, we looked at the facilitators, and then we came up with recommendations. There are barriers at the level of service provision, at the level of funding, workforce, data and information systems, technology, and governance. So these are for acute care services. For funding, for instance, barriers could be no national strategy, tension between public and private health systems, stroke is not a priority for government, no universal health coverage. And what are the facilitators? This was based on mixed methods, thematic analysis of HICs versus LMICs that was published in the Lancet Commission. Availability of services, universal health care coverage, data collection, which provides mechanism for funding through government. All of these are important. So our recommendation is that we need to collect data to drive decisions and lobby with government. I think MT is doing a fantastic job, which can be copied across the globe. Lobby for universal healthcare. So, and across all of these too, for workforce, training of people, data and information systems technology, there are different recommendations. This is in the supplementary material table 14 of the Lancet Commission. So, coming back and focusing on Africa specifically, large artery occlusion constitutes about 20%. This is from the Sub-Saharan study, which is the largest study of stroke in Africa. About 20% of all strokes, large vessel occlusion. And for large vessel occlusion, other places, about 30% of acute ischemic stroke. Thrombectomy is effective when the clot burden is high, and effective up to 24 hours. 90% of pre and will benefit. Is ineffective. That's talking about thrombolytic therapy when the clot burden is high and after 4.5 hours. And that is the place for thrombectomy, as we all know. Well, where is this happening across the globe? You can see that in Africa, only a handful of countries have this. And even within those countries, there are disparities. This also shows the same thing. Different people have looked at endovascular thrombectomy services in Africa and elsewhere. Let's look at neurologists. Again, you see that in many places, in some places, there is only one neurologist, or in fact, not even a single neurologist in level D countries to drive this change. But in some countries, you really have quite a number. So there are barriers, lack of neurologists, lack of trained personnel. Those are all very important. Neuroimaging facilities, again, if you look at that, you also see that for CT scanners or MRI scanners, many countries have very few. That is not enough for their population. So, stroke systems of care availability, a lot of challenges. Red means there are issues, while green means available. So, if you look at endovascular thrombectomy, you can see that less than 20% says that's available. So stroke specific training in reperfusion therapy, building training. These are some of the priorities, based on our what the African Stroke Organization summits. These are the priorities that should be focused on in setting up acute stroke unit, building and training auxiliary stroke team, and reperfusion therapy in acute stroke. So what are the challenges? The EVT workflow chain. You can see what happens. If stroke happens, needs to be recognized. There should be an ambulance service. Patient gets to the hospital. Imaging is done, and a decision is taken if it is a large artery occlusion, whether EVT will be needed. And of course, then there must be the neurosurgeon or the vascular, the neurointerventionist who is going to do this, must be available. And of course, anesthetist, ICU bed. So all of these are in the care continuum, which needs to be provided. So there are barriers, patient-related, not recognizing that a stroke has even happened. And that's why it's very important to sensitize the public so they can recognize stroke with FAST or BFAST and get a hotline, healthcare professional related, facility related, and oversight function problems. So, but we are lucky that there is a neurology revolution which we can leverage even in Africa. The global synergistic actions are required to improve brain health for human development. Brain health is central to health. Without brain health, there is no health. Without health, there is no SDG. So brain health is central to all of health. And it's important to prioritize brain health. And this is happening now. Even in some African countries, Cameroon, for instance, has put brain health as the center of their developmental agenda and not just at the center of the health ecosystem. And this is something that may be a model for other countries if this works out. So the WHO IGAP was launched in 2022, and these are some of the concepts for all neurological conditions. The continuum of care is important. Acute treatment is what we are focusing on. NCDs and universal coverage primary health care. These are all very important. Ecosystems are important, which means we are not only dealing with policymakers, and MT has done so well with this. Patients and caregivers are important. Payers, funders, general population, through social media and other media, providers, practitioners. So implementation partners, who can be better implementation partners than MT 2020 plus, or MC now, no longer MT 2020 plus, and VIN are the most important implementation partners for this. But we have to also leverage not only WHO, United Nations, but also World Bank, World Economic Forum, and other organizations that have been formed. So ARISIS is African Rigorous Innovative Stroke Epidemiological Surveillance, which we just set up. And essentially, it includes a stroke alert system and a stroke finding system. We set it up for epidemiological purposes, but we also want to use it to fast track access to care. So training programs which we are involved in, Talent Grasp, and the WSO training program, part of which was part of what we did in the just concluded African Stroke Organization conference, which was hosted in Zambia. So building thrombectomy systems in our communities require high volume treatment facilities, advanced imaging, post-hospital care, dedicated neurointensive care unit, peer review publications, so that people know what is happening, and new techniques and methods that are more efficient can be proposed through research. So some of the activities, African Stroke Organization, like I mentioned, we just did our fourth hybrid conference, Controlling the Burden of Stroke, Gateway to Reducing the Burden of NCDs, hosted in Zambia. And we have these programs, GRASP, which is brain health and data science and talents for training neurologists and then neuro professionals or neuroscientists to promote brain health across the globe. And we are also leading the Lancet Commission on Neurorehabilitation, which is very important. And I've invited a few of us to be part of this. I want to thank the Lancet Commission, the commissioners who participated in coming up with those things. Paul Uluoyo, who helped me to prepare some of these slides. The Lancet Commission was on the 200th year anniversary of the Lancet. Thank you so very much. Hopefully, as we go on with this, MT will continue to support the implementation, particularly of acute care services across Africa and indeed across the globe. Thank you so very much.